welcome to all of you to this, the second of the series of our thematic innovation ecosystems on integrated care. We're doing this in collaboration with our Scottish ecosystems and the Yacova project. And the purpose of today will become clear to those people who've not been involved. Many of you have been here before at the previous sessions, and I say hello to our colleagues from ecosystems in Italy and in Spain and elsewhere across our network, and also welcome other members who have joined from today who are our previous sessions. Just a little bit about the European Connected Health Alliance, who we are. We're a member organisation, as you can see in front of you. People join us because they want to get connected with organisations that you can see here today, but also a wider connection of people, 850 different organisations, 20,000 experts across the globe. We bring those together in a series of both geographic ecosystems, such as in Scotland and Catalonia, but also on thematic areas, and I'll come on to those in a moment. We're a not-for-profit body, so you know who we are. We also run a number of other events as well. We're closely linked to colleagues who are presenting today, and we're very grateful that the fact that the Scottish ecosystem and Digital Health and Care Scotland have helped us not only with the integrated care thematic ecosystem, but also the same one on digital health and wellbeing. People join us for the reasons you see in front of you. I'm not going to spend any time talking about that. I'll stick a link in if you want to join us in the chat function when I finish speaking. But what I want to talk about is our ecosystems. We've set these up 10 years ago. I attended one of the first ones in Manchester in England in the UK. And I joined because I wanted to get in contact with innovators, industry partners. I brought with me patient groups and citizen groups. Our ecosystems bring all of those partners together, all of those stakeholders in health, in what we call permanent multi-stakeholder gatherings, which used to be just geographic, and we've got 70 of those, and I'll show you those in a moment, but also now in a series of thematic ecosystems, such as the one we're at today, dwelling on integrated care or mental health. Those ecosystems, whether they're geographic or thematic, are there for three main reasons. They're there to break down silos, because they're still as prevalent as when I started in healthcare 30 years ago. In different ways, but they're still there. They're there to transform healthcare, i.e. to do stuff, not just talk about it. But they're also there because they're there to create economic growth, because our largest spend area is in health and social care, but probably with the exception of a few countries, or maybe those countries that spend more on education. We've set up a series of these networks of ecosystems, and there's now 70 across the globe, and they are there primarily to match need and solution, bringing them together and collaborating. Nothing more complicated than that. No other fancy diagrams are needed, no tables. Matching need and solution should be paramount, I think, to people who work in healthcare. We've set up an ecosystem network, as you can see in front of you, that incorporates a load of the people who are here today. So if you're involved with those ecosystems, raise your hand in the chat function down at the bottom of the screen. If you're not involved with that network, why not? Come and join us. I'm particularly pleased to see we've got colleagues from Slovakia here today. They'd be more than welcome in that network and would help boost that European presence we've got across Europe with networks of ecosystems in Finland and Spain and the UK, but also building in Norway and that Nordic cluster, and in Latin America too. And we're pleased also to see people taking part from our Argentina ecosystem. So hi to you as well today. We've also just recently opened up our 70th ecosystem in Japan. Strange enough, we're there as a global connector. We used our Scottish ecosystem, or colleagues from Scottish ecosystem, as part of that launch, because we believe in sharing good practice and the best practice across our network. But as I said, we're not here today to talk about those. We're concentrating on that thematic area. And today, and you see on the bottom left, the first idea we had for a thematic ecosystem was around integrated care. And we want to use these thematics to go and do a deep dive, to pick out that best practice, to showcase those impacts on policy, those best practices, the best of the best we've got, not just across Europe, but across our wide global connections of 70 odd ecosystems. And why wouldn't we? Because we've got to keep sharing those best practice examples. And today we're going to hear from two, I think, fantastic showcases, both from either Slovakia and also from our Catalonian ecosystem. And we're really pleased to be able to bring that, again, with partnership with Scottish Digital Health and Care and the Yacova project. I'm going to stop talking now, and I'm going to hand back over to Nessa for our next speaker.
Thank you very much, Andy. And as Andy said, we'll put some links into the chat so you can find out more about the ecosystems if you wish to after today's session. So I'm really delighted to say our first speaker is Dr. Susana Yacova. I'm sure I've got that wrong, Susana, so apologies if I mangled it. Susana is based at Pavlov Josef Sarafik University in Slovakia. I'm going to get this wrong, apologies again. But Susana is also chairman of the Slovak Public Health Association and regional coordinator with IT in the Ministry of Health. And Susana is going to speak about the experience that they've been having in relation to integrated care and just some of the reflections over this time. Susana, over to you.
Thank you, Nessa. Good morning, everybody. And thank you very much once again for opportunity to be here today. And I hope that you already see my first slide. And I would like to today take you briefly on the path we have taken in finding solutions to reduce the impact of COVID-19 on vulnerable groups during the second wave in Slovakia. Today, I would like to share our experience with you, starting with setting the scene, going through the birth and life cycle of a new integrated care-based project and ending with its future. So let me start with a return to the short past, a little over a year ago, when the first self-assessment process was performed in Slovakia by using the Shiroko Exchange tool on maturity and readiness to change in implementation of integrated care. The assessment was done at regional level within Košice region, and the process uncovered several important facts. The maturity level assessment found the lowest value in the 4 dimensions, as you can see, and of those, the structure and governance dimension seemed to be the most important starting point that might help to facilitate the process of adoption and implementation of other inevitable change. Only 1 dimension, process coordination, was able to reach higher but still not satisfactory level of maturity. 2 more strengths were recognized. Firstly, the existence of several national and regional strategic documents on integrated care in Slovakia that emphasize integrated care approaches, but without real progress on the perspective of implementation. And secondly, potential for cooperation within integrated care between professionals in the health and social care systems, even thought for time being without clear vision, planning, or management of this collaboration on governance level. At the same time, during spring, it was also the period when strict lockdowns, as you can remember, helped Slovakia and other Central European countries handle the COVID crisis better than Western Europe. However, 3 months later, after June's gathering, around 2,000 people on Prague's Charles Bridge for a party billed as a symbolic farewell to the crisis, the picture looked far darker. In between the 2 waves, the Eastern European countries relaxed its measures farther than the West and was then less eager in reimposing them. Eastern Europe squandered its spring gains and then repeated the mistakes made by the Western Europe. In spring, one explanation of this reluctance to reintroduce restrictions might be that these countries have fallen victims of their own success. Eastern Europe contained the virus so successfully in spring that they didn't experience the horrific hospital scenes seen, for example, in northern Italy. This might have produced skepticism about the severity of the pandemic. And that is why in the beginning of autumn 2020, we in Slovakia could only estimate what the incidence curve of the COVID-19 is ahead of us and rely on the experience of other countries. Based on this, we looked for strategies to help those who already were at the highest risk for the pandemics. Therefore, in September 2020, medical doctor from Bratislava, who is clinical specialist on infectious diseases with many years of experience in tropical countries, came up fortunately with the idea to build up prevention of the spread of the virus among the most vulnerable groups in Slovakia on an alert and emergency intervention system. Using the bottom-up approach, we as the Shiroko Exchange project national partner and team fully supported her project proposal on tackling the COVID-19 in groups at the highest risk and were ready to participate in its implementation. Of course, for starting such project, the political support was inevitable. Moreover, because the newly elected government governed the country at this time and the Ministry of Health had no ready solutions, this pilot project received approval from the Ministry of Health, as well as partial structural and financial support. At the end of September 2020, based on the project proposal, the intervention team of the Ministry of Health of the Slovak Republic was established within the pandemic plan and under the auspices of the operating center of the Ministry of Health. The intervention team decided to develop the alert and emergency intervention system and to orient its help towards two target groups: older people living in permanent social care facilities because of rapid spread of virus, severe course and mortality due to COVID-19, and also marginalized communities because rapid spread of the virus, but also because of limited access to healthcare, limitations on compliance with anti-epidemic measures. The mission of the team was formulated with aim to provide early short-term medical and psychosocial intervention in the case of reporting occurrence of suspected and or confirmed cases in target groups through so-called regional multidisciplinary teams. As important members of each regional team, the following professionals were identified: team coordinator and logistics as key managers in the field, GP or nurse and medical students and expert on psychosocial support as key members of performing intervention in the field, and finally, epidemiologist, expert on infectious diseases, internist and pathologist, who were usually used for on-call consultation of the current situation and problems. How the whole process was managed. Each alert on suspected or confirmed case of COVID-19 infection was received and processed continuously by regional coordinator, followed by immediate phone consultation and, if necessary, on-site planning. Based on estimated needs, mobilization of the field coordinator and the local team for on-site assessment and intervention was planned and performed. After the on-site intervention, the further actions were done to achieve ensuring the stabilization of situation. Reassessment of the situation as last step was used to hand over the alert or to continue with the process. The most important action areas included telephone consultation, on-site interventions, short-term support, and mobile vaccination. Telephone consultation predominantly focused on collection of information based on areas of interest of the problem solving, like local epidemic situation, team capacity, availability of resources, but also to evaluation of information and to come up to consensus on the follow-up steps. On-site intervention covered assessment of the situation in the field, followed by the rapid medical and psychosocial intervention, which usually included the tasks like testing, consulting health status, psychological intervention, education in the community, and advice on the implementation of measures to prevent and control the spread of the virus. When lack of personnel raised as a need, especially in permanent social care facilities, to stabilize the situation, the 7 days intervention in field was organized and was oriented primarily to daily monitoring of health status and training of staff in relation to having the virus under the control as much as possible. As we knew from our field work that our target groups, especially the marginalized Roma communities, had very limited access to vaccination During summer 2021, we decided to enlarge our activities on low threshold mobile vaccination. Within this action, we actively approached and collaborated with self-government and provided whole process coordination, starting from verification of interest to the process of organizational preparation of vaccination, but also including post-vaccination telephone counseling. The main outcomes achieved after 6 months of action, but also later, are listed here. More than 170 alerts and similar number of short-term intervention, more than 50 psychological interventions, and more than 5,300 hours of support directly in the field. We were in contact with more than 266 facilities and communities, and we provide vaccination to more than 6,000 people. And we also did 2 online surveys during our actions, which were oriented on mapping the needs in the beginning of the second wave, especially in permanent social care facilities, and also mapping on satisfaction of our target groups with the interventions. On September 10, 2021, approximately after a year of its existence, the intervention team of the Ministry of Health became one of the organizations awarded the Ministry of Labour, Social Affairs and Family with a prize called the Social Act of the Year. All the efforts made led to the results achieved thanks to close collaboration and networking of key partners, which included Ministry of Health, Labour, Social Affairs and Family and Interior, especially then the national and regional public health authorities, general practitioners, self-government, and also, last but not least, NGOs from local regions and also private healthcare providers. Looking back to the past, we see the following strengths, weaknesses, and opportunities related to the existence and operation of the intervention team of the Ministry of Health today. NGOs and individual stakeholders with awareness on integrated care action, very well coordinated multidisciplinary teamwork with highly motivated voluntaries, especially from medical students, but also partial political, governmental, and institutional support, we consider to be crucial aspects of its success. On the other hand, lacking health professionals from practice, less financial and structural support as would be needed, and lacking permanent core team for the field work, and also no existing pathways and documentation for the action area present important weaknesses of the health process. Lessening the impact of COVID-19, but also other pandemics on vulnerable groups relates to increasing scope of rapid responses to a variety of disease-related situations, as well to engaging target vulnerable communities in disaster risk reduction and preparedness from long-term perspective. As the intervention team, we do not know how long the future lies ahead. We are currently ready and continuing our activities in the third wave, and we remain in the hope that this pilot project in Slovakia will receive long-term structural support and become an example of good practice. Thank you very much for your attention.
Thank you very much, Susana, for this impressive presentation. So without further ado, we will move on to the second speaker. In the meantime, please use the chat to ask the questions or any remarks for Susana so that we can pick them up during the discussion. So now we will move on to the Juan Carlos Contal from Department of Health Chronic Care Program, Integrated Health and Social Care Plan from the Government of Catalonia. Juan Carlos, over to you.
Okay, morning. I'm very happy to stay here and thank you very much for this kind of opportunity, to talk about the situation and the lessons learned during the pandemics, and which kind of impact in integrated care we have had during the pandemics. I am working at the Department of Health and I am working in the chronic care program, and together we have integrated health and social care plan with the Department of Social Affairs together. Okay, The situation in Catalonia, we have two departments, the Department of Health and the Department of Social Affairs, and they have different kind of responsibilities. And now we are trying to work in a more integrated way, especially in residential homes, in nursing homes, and also in home care. The situation of long-term care system in Catalonia, we have different kind of layers. You could see here, we have the home health care provided by primary health care centers, but also we have social home care, especially supporting care and support for activities of daily living. And it is performed by the Department of Social Affairs together with the local governments, the municipalities. Second layer, it is related to intermediate care. We have a very good network of intermediate care centers, long-term care centers with different kind of beds and different kind of services, related especially for geriatric population and disabled people. And we have about almost 70,000 people who are living in residential homes, in nursing homes. In the case of the nursing homes, there is a distribution of responsibilities between the Department of Social Affairs and the Department of Health. The responsible to take the care of in nursing homes, it is a responsibility by law of the Department of Social Affairs, but it is expected collaboration from the primary healthcare centers to cope with some kind of needs in the nursing homes. What has happened in the case of the pandemics? Situation maybe it's a little different comparing to Slovakia. You could see here the impact, as we have all the primary health centers well connected to the nursing homes. We have introduced from a long time ago the primary healthcare electronic health record inside the nursing homes, and it's possible to get very good information about what happens inside the nursing homes. And you could see here the impact of the COVID pandemics, specifically in the case of the people who are living in residential care. And you could see, for example, the impact of the first wave. It is, for example, some days during the first wave, we have over 500 people infected during the first wave. I think the impact was very huge and with a lot of impact during this kind of wave. What about hospitalization? In the case of hospitalization, you could see some days it is the daily, the mean daily basis, that is hospitalizations of people living in nursing homes. It is over 150 during the first wave. I think it's very high rate of hospitalization in this kind of population. Or for example, in the case of the death, we have in the first wave over 200 people died in one day. I think it's, you could see now the situation now in Catalonia of people living in nursing homes, it's 1 people per day. I think the situation is completely different, but you could imagine what kind of impact we have had during the first wave. What kind of actions we have implemented? Some of the actions are very similar to the things Susana has explained about the general measures, different kind of things, working together with public health. But we have developed some kind of specific things I would like to summarize. One is to have some kind of joint interdisciplinary team among both ministries, the Ministry of Health and Social Affairs. The second one is the creation of new posts of territorial delegates. They are responsible to put in actions the decisions of the government related to COVID pandemics. We have created, we haven't not had in the past, but we have created some kind of decentralized territorial structure of the Department of Social Affairs. We have a coordinator of the Department of Social Affairs working together with the coordinator in the county of the Department of Health. We have established the rules of sectorization, isolation, and the different kind of things included in the protocols. We have created some kind of nursing homes which they act as a buffer nursing homes where you are referring some kind of patients from ordinary nursing homes to be treated in a more advanced way, specifically with oxygen and different kind of technology. We have involved a lot the role of the primary healthcare. The primary healthcare teams in Catalonia, we have a very good model of primary healthcare, and they have been very involved and committed, especially in the first wave, to cope with this kind of population. And we have introduced the primary care electronic health record in almost all the residential homes. You could see here, that's a picture and numbers of the involvement of primary healthcare teams. That's the weekly number of visits of primary health teams in Catalonia. You could see here in the first wave, maybe in a week we have over 20,000 visits per week. No? In the case of primary healthcare teams working together with the nursing homes, the situation now it's lower, but there is some kind of maintained commitment and involvement of primary healthcare to cope with this kind of populations. Another kind of impact, it is the use of e-consultation, electronic consultation by citizens, and the use of electronic consultations by professionals. You could see here, before the pandemics, it's about 60% of the professionals are using this kind of e-consultation, electronic consultation, and now it's almost all the professionals are working through the primary health electronic health record. They are working with the citizens in this kind of way. And in the case of the citizens, you could see before the pandemics, it was about 1-2%, I think very low use of this kind of electronic consultation. And now it's a quarter of the citizens, they have used in the last 12 months this kind of technology, in these kind of things. Another important thing to share with you, it is the use of Sirocco after in the more advanced stage of the pandemics, because we have teams working in territory. We have tried to use Sirocco. We have consulted about almost 200 professionals in 18 counties or territories. We have the division of this kind of work, and you could see here some kind of, we have made some kind of photo of the status in 2020, and 1 year later, in the advanced stage of the pandemic, you could see difference in the Sirocco score performing in the different kind of dimensions. And you could see, for example, we have better position in readiness to change, structure and governance, coordination and processes, and digital infrastructure. You could see some difference between the 2020 situation and the later situation in 2021. Here you could see some kind of the presentation of the picture in one of rural areas of the 18 territories we have performed Sirocco, and you could see the difference of the base situation and 1 year later situation compared with the basic situation. That's in the city, I think in the city of Barcelona, that is a division of Barcelona in the north of Barcelona. You could see here in a metropolitan area, which is the performing. The situation before was very low, and we have improved in the position of the different kind of scores in the different dimensions. What kind of conclusions? I think it's interesting in the case of Sirocco, not only it's important the score, the quantitative score, but also I think it's very important to know about the conversations and the distillation of the lessons learned. I think it's very interesting. For example, here a summary of some kind of things we have commented in the groups. For example, pandemics has generated change, but no strategic planning is required in the future. We need long-term care vision. We need to formalize and regulate as in Scotland and in other countries, in England, the formal governance arrangements, to make this kind of formalized governance for the future. It has been very positive, the use of primary care electronic health record, but this kind of electronic health record is not prepared, is not fitting well for the needs in residential homes. And we need to develop new functionalities, adapted to the situation of nursing homes. Good impact of, we have created new posts of primary care case managers, nurses, who are working together from primary health care, working together with the nursing homes to try to make case management, especially for patients who are more complex, no? And to link this kind of patients and the residential homes to all the health and care system. And other things about to improve the labor conditions and the nursing workforce is lower, it's worse in the case of nursing homes compared with the situation in the health sector. The salaries are lower and the labor conditions are not so good. And we have a great potential of aggregate and perform joint analysis of data. I will show some kind of analysis we have made now at this moment. Yes, different kind of things. We have a lot of conclusions you could see when I share the presentation, but the conversations and the learning has been very rich, no, to make this kind of joint reflections about the situation. Another important thing in this time, we have created some kind of scoreboard because we have connected the primary health record with the nursing homes. It's possible to get information related to activity, a different kind of indicators, no? For example, and we have this kind of information not only for all Catalonia, but it's possible to go to a county level, and it's possible to go to nursing home care level. I think it's possible to know what kind of proportion of complex patients you have in every nursing home. It's possible to know this kind of information. We see a lot of difference between the different kind of counties and nursing homes, and it's interesting to make some kind of benchmarking process with this kind of information. Another important work we have performed is in home care. In the case of home care, we have developed, that is the first time we are using some kind of aggregation and integration of data provided from the health sector, the primary health sector, and the social care sector. The first part of this study, we have at county level and in social care center, we have made a survey, a questionnaire with questions related to 5 dimensions. One dimension is what is the perception of integrated care related to this kind of things. Integrate individual assessment, unique or share individual care plan, share protocols or pathway, coordination between social and health teams, and if you have some kind of portfolio of joint social and health services in the case of home care. You could see the position and the scores are very low. The situation is about 2.7 of 10 points. In the case, the same question in the case of the primary healthcare centers, they have scored in a better way, but the situation, the situation is very low compared with the expected situation we would like to know. Another important thing is to know about what happens with the people who are receiving social home care related to supporting activities of daily living or instrumental activities of daily living. You could see here the red color is related to higher burden of complexity or multimorbidity. You could see on the right side, you could see more than half of the population, they have a very high burden of multimorbidity in the case of the people in social home care. Another important thing is to know about what happens with the people with social home care, what kind of chronic conditions they have. In the case of the social home care, they have more dementia and more psychiatric conditions compared with another kind of populations. That is an interesting picture. Red color is higher burden of multimorbidity. In the center, you could see people who has social home care and plus home health care provided by primary health care. You could see here the burden of multimorbidity is higher compared with other kind of populations. On the right, people who has home health care and no social home care. And on the left, we have people with social home care and no home health care. And you could see the different kind of patterns of burden of multimorbidity of these kind of types of population we have with this kind of services. Another about the impact. We have established some kind of analysis of territories where the perception of integrated care is higher, is good, compared with conventional territories where the perception of integrated care or integrated home care is not so good. No, we have the intervention arm and the control arm. And you could see here which is the impact. In the case of integrate, better performance, better score of integrated home care, they have more primary healthcare visits, more primary healthcare home visits, more hospital admissions, but not significant, more emergency or accident and emergency visits, but not significant. And we have decreasing accumulative admission days, but they are related to because they have less nursing home admissions. You will see, we don't have impact in mortality, but we have identified that is the main result of this kind of study. We have an impact in the integrated home care territories with better score. We have decreased the number of admissions in nursing homes by 20%. Maybe that is the most important figure related to this kind of study. And it is related to the cost. It's very similar to the pattern of utilization of services. And that's all. I think that is a starting point. We are very happy because that is the first time we could aggregate information from the health and social sector because it's very difficult according to protection data allows to have this kind of exercise and analysis. Okay, thank you very much. I'm very happy to be ready for your questions.
Thank you very much, Juan Carlos, for a very inspiring presentation. So we will now open the discussion. So if maybe perhaps the speakers, yeah, so thank you, Susana, for putting up your camera. So we'll start with the question from Stuart, and then we will move on. Stuart, there was a question around, well, for Susana to start with, around effectiveness of an integrated care approach and how this can be basically sustainable and scale up to the overall system. But Stuart, you perhaps want to step in and formulate your question yourself for Susana?
I guess you can hear me okay on there. Yeah?
Oh, Stuart, your audio is a little bit wobbly.
Okay, well, actually, I'm going to do a fine job of presenting it. Let's just get that. Yeah.
I'm not sure what you said, but I'm going to think you said that Andrea could read your question. Is that it?
So yeah, I think I'll read
maybe the chat.
Yeah, I'll read it out again just from the chat. I just wanted to make it a bit more interactive. So there was a question from Stuart around, yes, I was saying the experience that Susana, you share with us demonstrates the effectiveness of an integrated care approach. What do you think it would take to scale over the whole system? And it could be cost effective. And that was quite similar question to me about the sustainability of presented intervention.
Mm-hmm. Thank you for the question. To be honest, I have to say that we as an intervention team definitely have this ambition to continue and to stay in close collaboration with the government and with the ministries and somehow to try to keep it as sustainable, as we see that this type of existing of this type of team within the governmental structure, at least in some lower structuring, should be very important, not just because of COVID-19. So we have this ambition, and currently we also provide much more permanent information. So the ministry started to be more interested in more details, how we work, what are the results. So we started to provide them also kind of monthly basis reports on our work. So I hope that also this information will be helpful for them to more understand and to better see the importance of such organizational structure for the future.
Okay, thank you very much, Susana. Then the next question from chat was from Anne-Henri for Juan Carlos. Anne-Henri, do you want to step in, or do you want me just to read out your question? Me also, I'll just read it out. So Anne was saying, impressive support for care homes from primary care. How involved were your specialist intermediate care teams as part of this integrated support for all the residents?
Yes, we have support. Yes, we have support from primary health care, but also from intermediate care. In some cases, especially for people who need extra care or more advanced support for this kind of people, the acute hospital has not been the best option. In some cases, we have be supported by intermediate care facilities. We have converted and contracted some beds from intermediate care network to take care and to support in this way. And another kind of strategy we have developed in Catalonia is we have converted some nursing homes, some special nursing homes with better infrastructure or better physical conditions. We have contracted some kind of beds, like if they are intermediate care facility. We have established, we have converted in a temporary time, this kind of nursing homes with better support, with oxygen and nursing skills to give support, especially people infected and who need extra support and care. There are the two lines to work. One is to involve intermediate care and also to create this kind of buffer nursing homes. They are reference nursing homes, but there are like intermediate care facility, very similar to the contents and the services which we provide by intermediate care, ordinary intermediate care facility.
Thank you very much. And if you don't mind, I'll just stay with you for the next question, which was posed by Stuart. So again, I'll just read out that one. Stuart was picking up on the aspect that obviously many older people are also supported by informal care from family and the community. So he was asking, what do you see as the main challenges in providing better support and information gathering that crosses into the informal care context as well?
The case of person-centered care during the pandemics, it was very curious because we had worked in an agenda of person-centered care in some kind of scenarios of co-creation. But during the pandemics, the dynamics is another kind of dynamic. The people who are used to working in these kind of situations, and I think we have a lack of person-centered care approach. And I think after the pandemic, or in this stage of the pandemic, I think it's very important to recover the dynamics of co-creation and person-centered care, to redesign the services we are performing, not only in residential homes, but also in home care. I think maybe one of the consequences of the pandemic is not to take account enough the needs of the families and these kind of things, especially in an emergency situation like it is the pandemic, especially in Spain and in Catalonia during the first wave. I think now it's time to recover some of the dynamics and maybe to rethink a lot of ordinary things we have in residential homes and also in home care, with the co-participation and co-creation with the families and the patients.
Thank you very much. Susana, did you have any experience with the context of informal care within your kind of like interventions teams?
I would say not directly within intervention team, more from other part of my work, but within intervention team and situations in the field, especially in social care facilities, it was more about the communication, because especially in these permanent social care facilities during the COVID-19, it was the problem, because the communication and entrance of the informal careers was quite long forbidden, for example. And in relation to informal careers at home, I know that especially patients' organizations were very supportive in Slovakia, that also they used especially phone calls and involved voluntaries and at regional level to help, for example, and to stay in contact with informal careers. So this was the way how it works in Slovakia during the pandemics.
Okay, great. And you know, obviously we were talking about informal care now, and I also see the question from Andy about the voluntary groups. You know, where do you see the opportunities to include more the voluntary groups in the delivering integrated care? It's probably a question for both of you. Yeah, Zana, you want to go first?
I can continue shortly. So yeah, especially in relation, again, not just to intervention team, but definitely in the field of integrated care, we see a lot of challenges for more involvement of voluntary groups from not just from students, for example, but also from older people who are still active and are able to be helpful to others who are in need. So this is something what I see as a challenge, for example, in Slovakia in comparison to other countries. So definitely we see these opportunities through some also patients organizations, but not only.
Another important thing, for example, in the case of residential homes, we have had a lot of problems. You should balance the protocol, especially when you have a wave, especially the first, the second wave, when you have a protocol and you have restrictions on the visits of the caregivers, no, in the residential homes. We have had some problems with the associations of caregivers and different kind of groups of interest, because they are needing to be more close to the people who are living in nursing homes. And it's very difficult to make an appropriate balance of the emotional needs of the caregivers and also the people who are living in residential homes, and the regulations or the protocols where some of the actions is to restrict the visits of the people who are, of the caregivers who are living at home, and they would like to visit daily or visit sometimes a week to the people who are living in nursing homes. For us, it has been very painful, because sometimes we should take decisions related to restrictions, and it's very difficult to have or to take some decisions related to this issue.
Thank you very much. And I'll actually pick up another question from Andy, which I think is quite interesting and provocative, I think at the same time. So it's, I think, yeah, a question for both of you and also maybe for other participants at the webinar. If you see any evidence or experience any evidence of political pressures to empty out hospitals. I don't know, Andy, if you want to kind of like pose that question yourself or elaborate, or is that enough?
I think there's a couple of countries we've had where I've been on a call earlier on this morning, not from the UK, and there's been pressures again because of another wave to move people out to the same old places, the nursing homes, the family houses, the residential care places, or other less formalized care. But with that, as we've seen in countries that have done that too early, the added risk is of increased infection and lack of monitoring. So I'm wondering if that's been the case in in Slovakia or in Catalonia, or even amongst other participants today, whether it's in Greece or in Italy, or in Argentina. I don't know if Andrew is still on. Where there's been that political pressure and how it's been managed, because obviously political pressure is by nature political and comes with a whole bunch of problems.
If I may add from our experience as interventional team, we saw also another problem, not pressure to empty out hospitals, but pressure to get hospitals fully because of a higher number of COVID patients. And that was one of the reasons why they were very happy that we started to help, for example, in these permanent social care facilities, because in the beginning there was a big afraid from staff in these facilities, and they immediately sent people because of COVID to the hospital. So it was also quite interesting situation that the numbers starting to increase, and they needed to stabilize the situation somehow. So it was related directly to the COVID cases. But on the other hand, there was also opposite situation that in hospitals, as they are afraid of increased number of infected people directly in the hospitals, they tried to shorten the periods of other health problems, people hospitalized, and get them out as soon as possible.
Yes, in the case of Catalonia, there is a difference between the first and second wave and the last waves. No? I think at the beginning it was an explosion, and it was like a bomb, a tsunami of people infected and with no experience about how to manage this kind of patients. And we have, the hospital was full, and in some cases we have established some kind of protocols to prioritize what kind of patients could be treated, not only in the hospitals, but also in intensive care units. No? In some cases, we have problems, especially to accept in acute hospitals some kind of elderly population, especially people over 80. But maybe one of the solutions, good solutions, is the involvement of intermediate care and to create this kind of structure of nursing home, buffer nursing homes or reference nursing homes, where it's possible to reinforce the equipment of this kind of resources, no, to cope, especially when you are in the peak of the wave. No, you have a lot of people in the hospital, and maybe you have the risk not be treated, no, because the hospital is full. No, the situation now it's more balanced, and I think it's another kind of situation. But in the first and especially the first wave, and also maybe in the second wave, we have had problems in this way because it was a very urgent and explosive situation, very difficult to manage.
Thank you very much for this interesting insights, both of you. Just maybe continuing with you, Juan Carlos, because I've seen a lot the question around sustainability of increased use of digital services. You had that impressive graph when you illustrated that almost over 90 healthcare professionals have been using the virtual consultations and other digital tools, the same as the increase of citizens using these tools. Do you think that this is something sustainable, or is it something just that we experienced during the pandemic's time? Because I think this is quite similar for many other regions and countries that we see that increase. But is it something that you think will stay?
Yes, we are very happy, and the people working in the information system department, they are very happy because it has been a very good opportunity not to develop different kind of initiatives, no, and to introduce these kind of channels. I remember, for example, some year ago, we are trying not to reinforce the citizen could use this kind of electronic consultation or these kind of things, but it was very difficult only by talking. But with the pandemics and with some of the restrictions, a lot of citizens, they have used to using this kind of channel, no? And it's the same in the case of professionals, because in some cases, especially when you have a wave, The virtual consultation, in some cases, it's safer depending on the situation and the need of the patient. And I think the acceptance of the patients and the acceptance of the professional has been changed, you know, along the pandemics. Now, maybe there are some kind of emphasis of the government to try to recover some kind of face-to-face visits. But I think maybe we will have some kind of balance between face-to-face visits and also virtual visits, no? I think it seems to me will not decrease the number or the volume, the volume of virtual visits, but maybe we will have more balance because some people will like to recover the face-to-face and to touch, no, the health professional, the care professional.
Thank you very much, Juan Carlos. And perhaps we still have 2 minutes to go, so I'll pick up one last question from Oscar Zanuto, and then we'll just wrap up today's webinar. So there was a question, if you have any integrated actions done in the area of dementia.
In the area of, yes, in the area of dementia, we are working in a plan specific of dementia, but in some cases, people with dementia, they are complex patients or people with advanced chronic disease. And most of these patients are not treated specifically as only as a dementia patient, as a complex patient. No? And the idea is to work in the complex care program we have. And I think it's interesting to introduce some kind of comprehensive approach, not only a specific and separate and a specific approach only for dementia patients.
Thank you, Juan Carlos. Susana, any insights from your side?
Yes, fortunately, currently we at the university level, our department is coordinator of a research project supported by the Ministry of Education. And it is project oriented on preventing the burden of careers of people with dementia. You can see behind of me also the banner currently, because we started just in the beginning of September with one of the activity within this research project, and it is activity oriented on self-help groups for informal careers of people with dementia, especially with Alzheimer's disease. And also we have planned to work on an online tool in a collaboration with WHO currently, which will be also available kind of e-learning material for people and for careers of people with dementia. And finally, we also prepare workshops for formal careers for next year. So these 3 activities will be a basis, and they are interlinked also with the research, which is oriented on measuring the health-related quality of life, and also on a level of burden of informal and formal careers of people with dementia. And as a result of this project, we also have the final aim to prepare also kind of recommendations, again, in relation to long-term planning and also in relation to current plan on reform, national reform, as one of the priority of this reform is also the mental health area. So we plan to be active also in this field as a faculty or as a department of social and behavioral medicine.
Thank you very much, Susana. That's impressive. And there have been a couple of other links in the chat to a couple of other resources on dementia. So we'll definitely share that with you also after the webinar. So I think that's I think it's a time to conclude and to wrap up. So first of all, thank you so much to our presenters for their very inspiring presentations, great discussion. As we were saying at the beginning, the webinar will be recorded. So we will share with you the link to the recording as well as the other resources which were shared during the chat. And as it was posted by my colleague Nessa, we would be very keen to also hear from you other topics that you would like to explore as part of this knowledge exchange under the thematic innovation ecosystem. So please get in touch with us so that identify the topic for the next webinar. I don't know, Andy, is there anything else to conclude from your side?
Just a plea for if you got from your ecosystems information such as we've heard today from Juan Carlos and Susana, please send it through to us. We will post it onto the Thematic Innovation Ecosystem webpage, where we've now got just about ready a separate page for each of our thematic innovation ecosystems. So whether you've got examples from Spain or other places across Europe, Italy, etc., such as Oscar's mentioned about dementia, please push that across. But we're also, as Andrea has said and Ness has said in the chat, we're keen to hear where you want to go next with this, because we could look at a whole range of different issues. We can look at the dementia issue. We can look, I know the Greek ecosystem, we want to look at pulmonary care and heart disease as well. So I know Theodore, who was on the call, was looking to do that perhaps next. Or we could do a mix of these integrated care topics. So email either Nessa, Andrea or myself, or all of us, or put it in the chat function now where you think that could be going, because it's one of the nice things about the thematic ecosystem is we can choose. We can go, next time we look at dementia, for instance, or heart disease, or data, or any other suggestions. So sticking your views in the comments box below, get involved, because I think, you know, the fantastic impact we've seen there from both Slovakia and from Catalonia has been very, very useful. And you could have changed the names of those places for any other ecosystem that we've got, because it looks very similar. That means to say we need to start sharing more of this data. So thank you very much for our speakers today. Susana, I'd love to be able to speak to you a bit further about Slovakia and where we can help you bring examples from Slovakia into our network of ecosystems. Juan Carlos, obviously we've got connections with yourself, with the Catalan ecosystem and our colleagues there, with Jordi and Julian in Barcelona too. So we'll make those connections too. We've had people on today we've not seen before from Argentina, which has been fantastic. I think that about wraps it up. Put your questions in below. Thanks to Scottish Health and Care for hosting this. Again, it takes a great deal of resources to plan these and publicise these, because people's demands on time are getting more and more, because people are meeting more often, but also, dare I say it, going back to work in offices where people actually sit next to each other and chat, as opposed to looking at a screen. So let's keep the conversation going. And I think that about wraps it up. Thank you very much.
Thank you very much, Andy. Thank you very much, everyone. So we will follow up shortly with the emails and with the next steps. It was really a pleasure to have you all with us. Enjoy the rest of your day. Goodbye.
Bye-bye. Thank
Bye.
you.
Bye.
Thank you, Juan Carlos.